Glucose is pioglitazone of the class thiazolidinedione, or TZD, with hypoglycemic action to treat diabetes mellitus. Glucose is available in 15 and 30 milligram tablets and is used for the treatment of type 2 diabetes mellitus in monotherapy and or in combination with other hypoglycemic agents. Glucose is used to improve glucose control in adults over the age of 18 with type 2 diabetes by selectively stimulating the nuclear receptor peroxisome proliferator activated receptor gamma and, to a lesser extent, the nuclear receptor peroxisome proliferator activated receptor alpha. These receptors modulate the transcription of the insulin-sensitive genes involved in the control of glucose and lipid metabolism in the muscle, adipose tissue, and the liver. As a result, and as documented by local drug assay tests performed at Centrotech Corporation, glucose reduces insulin resistance in the liver and peripheral tissues, increases the expense of insulin-dependent glucose, decreases withdrawal of glucose from the liver, reduces quantity of glucose, insulin, and glycated hemoglobin, or HbA1c, in the bloodstream. Glucose improve insulin sensitivity for better glycemic control.
Before we formally open this event, we would like to put down some reminders. This presentation is being recorded. During the duration of this webinar, kindly turn off your camera and keep your microphones on mute. For questions and clarifications, please type your concerns in the chat box. Our moderator will go through the questions during the open forum. Also, please remember to fill out the evaluation forms before leaving the webinar. A link will be provided in the chat box later. For this breakout session, we will learn about the challenges in managing diabetes in the elderly and how to approach it. This session will be presented by Dr. Edberto General. He is the chairman of the Department of Internal Medicine at the Bicol Regional Training and Teaching Hospital in the Daraga, Albay. He was also the former medical director of the University of Santo Tomas Legazpi Hospital. This session is moderated by Dr. Abigail Lejos Cureg, a practicing endocrinologist in Tuguegarao, who graduated from the Residency and Endocrinology Fellowship Training Program of the University of Santo Tomas Hospital.
Good morning. I would like to thank the Tiger for inviting me to speak in their first virtual conference. My topic is diabetes in the elderly. Diabetes, particularly type 2, is becoming more prevalent in the general population, especially in individuals older than 65 years. Older adults with diabetes present unique challenges that is usually not associated with the usual management for diabetes. These are the sources of my talk for today. Just like the general population with diabetes, older individuals are susceptible to the usual complications of diabetes. The prevalence rate of end-stage renal disease, retinopathy, heart attack, stroke, and peripheral vascular disease are increased by the presence of diabetes. About 50% of patients who have diabetes older than 65 years of age have already diabetic nephropathy, and the risk of lower extremity amputation increases tenfold among older individuals. DM type 2 is an interaction of lifestyle, genetics, and aging influences. The consistent decline in beta cell function and insulin secretion is very characteristic of aging. This impairs the life cell-induced insulin resistance and therefore results to progression of pre-diabetes to type 2 diabetes. Glucose toxicity from chronic exposure to hyperglycemia further worsen the insulin resistance and impairment in beta cell function. And the presence of visceral obesity results to lipotoxicity from chronic exposure to fat cell lipolysis, which add to this vicious cycle. The diagnosis and management of diabetes in these older adults is very challenging simply because the manifestation of diabetes is not as usual from the regular age group. They may present with classic osmotic symptoms such as thirst, polyuria, and nocturia, or they may be asymptomatic and just be detected on the regular examination. Some may outright present with metabolic disturbances such as DKA, hyperosmolar hyperglycemic state, or a mixed metabolic disturbance. Some may present with a spectrum of vague symptoms such as dementia, apathy, and mental confusion. And adding to this complexity of diagnosing and management of diabetes in older individuals is the presence of geriatric syndromes, which commonly is a constellation of falls, poor mobility, muscle weakness, urinary incontinence, unexplained weight loss, mental disturbance, as well as cognitive impairment. And there can be an increase in vulnerability and slow recovery from stroke, from repeated infections, as well as poor wound healing. And of course, these individuals, they might be taking a lot of medications for hypertension, for prostate hypertrophy, for COPD, dyslipidemia, and nutritional supplements, which really added to the complexity of managing this type of individuals. So how do we screen older adults with diabetes and prediabetes? So these more appropriate for older individuals who are at high risk. These are patients who are overweight and obese, those with first degree relatives with diabetes, those with history of cardiovascular disease, or those with hypertension with a blood pressure of more than 140 over 90, or those with medications for the hypertension. Also at high risk are those with HDL level of less than 35 milligrams per deciliter, or with triglyceride level of more than 250 milligrams per deciliter, and those with sleep apnea as well as physical inactivity. So what we use for screening? So we just like the general recommendation, we use the fasting plasma glucose and or the HbA1c. However, let's consider some things that will affect the value of your HbA1c. There are conditions that can falsely decrease your A1c. Hematologic conditions such as hemolytic anemia, sickle cell anemia, thalassemia, as well as recent transfusion can result to increase in the RBC turnover and therefore results to a falsely low HbA1c. Hemodialysis as well as erythropoietin therapy shorten the RBC lifespan and may result to similar results of A1c. There are conditions as well that may falsely increase the HbA1c. Age and race may be associated with an increase in insulin resistance. Your iron deficiency anemia may result to a longer glycation exposure, and your polycythemia may result to longer RBC lifespan that can increase or falsely increase your HbA1c. Anemia of chronic disease, on the other hand, can either falsely increase or decrease your A1c. So let me emphasize that we cannot just use the regular HbA1c for diagnosing diabetes. So it is recommended that the HbA1c to be used is certified by the NGSP and standardized with a DCCT trial assay. Now, if the result is normal, we repeat the screening every 2 years. So this is the criteria for diagnosing prediabetes as well as diabetes. So it has not changed for several years. It's still the same. Those with prediabetes are those with fasting plasma glucose of 100 to 125. Those with 2-hour postprandial of 140 to 199, or if you use the HbA1c, it's around 5.7 to 6.4. Those patients who will be labeled as to be having as diabetes are those with fasting plasma glucose of 126 on two consecutive or separate time, or those with 2-hour postprandial of 200 or more, and an HbA1c of 6.5% or greater. So if your patient is diagnosed to be having prediabetes, it's very important that if 2-hour glucose post OGTT is not yet done, we have to do it because in comparison with FBS and HbA1c, this type of test yields more patient with diabetes rather than the two other mentioned tests. So if your patient has prediabetes, lifestyle program should be initiated because in the diabetes prevention program, lifestyle modification which have an intention to decrease body weight and increase physical activity resulted in the decrease in progression of prediabetes to diabetes by 71% in 4 years. However, in these older individuals, metformin is not recommended for prediabetes. The FDA doesn't have any approval for this indication, probably because in the DPP trial, metformin was found to be not effective among individual aged 60 years old and above. And there are some meta-analyses that have shown that metformin treatment provides or results to a transitory effects on diabetes prevention. So in the assessment of older individuals with diabetes, it's very important to talk about or to look at their overall health framework because this will be the basis of the treatment strategies and goal that you're going to do to your patient. These comprised of medical conditions of your patient, as well as the functional status, which is the ability of your patient to perform the routine daily activities, which is necessary for their survival. Very important also to assess among this population is the presence of frailty. Frailty is the vulnerability of the individual to increased physical and physiological stress because of a decrease in physiologic reserve, resulting to a decrease in the performance capacity. Frailty involves assessment of the changes in mobility, the presence of falls, or inability to perform instrumental activity of daily living. Sarcopenia, on the other hand, is a age-related loss of muscle mass, which is linked to progressive loss of muscle strength and therefore decrease in performance of activities. These comprise of getting fall history, difficulty in mobility, as well as the ability of the patient to lift objects. Now, patients with diabetes is associated with increased risk of mild cognitive impairment. And this also associated with increased risk of conversion of mild cognitive impairment to dementia. Okay, so it has been said that the combination of cognitive impairment and diabetes may result to a poor diabetes self-management as well as control. It is also associated with increased risk of hospital admissions, increased occurrence of severe hypoglycemia, as well as increase in the occurrence of major cardiovascular events and death. You can assess your cognitive impairment by using a validated self-administered test or using the mini mental state examination or the Montreal Cognitive Assessment. So this is how you detect frailty. So basically, you just look at the change in mobility, the presence of falls, as well as assessing the presence of instrumental activity of daily living capacity. Now, for your physical impairment, this is how you screen them. And then this is a SARC-F questionnaire for screening for sarcopenia. So basically, you just assess the strength, the mobility, and the history of falls. This is how you assess the cognitive impairment. So on your screen is the guide for comprehensive assessment of older people. So you take the general health assessment, which includes your functional status, which you have to identify the ability of your patient to perform daily activity living and activities. You get the risk of fall, and then assess for cognitive impairment. You get the necessary social history, as well as determine the frailty and physical performance. For the general health test, we usually get the regular ECG, lipid panels. We assess the bone mineral density, as well as screen them for the presence of abdominal aortic aneurysm, as well as diabetes and cancer screening. So in diabetes specific health, we also screen them for the microvascular complications, assessing for the medical nutrition therapy, teaching them how to do diabetes management, as well as diabetes self-management training. So this is the Bloom et al. Category, which categorize adult patients aged 65 years and older, because this will be the basis of the treatment goals. So the category are as follows. Good health if your patient doesn't have any comorbidities, or they have 1 to 2 non-diabetes chronic illnesses, plus in the absence of activity of daily living impairments. Your patient will be classified as intermediate health if your patient has 3 or more non-diabetes chronic illnesses, or a mild cognitive impairment plus 2 activity of daily living impairment. Poor health are those with end-stage medical conditions, such as those with metastatic carcinoma, those who require auto-dependent lung disease, those who have end-stage renal disease or on hemodialysis, as well as those patients with advanced heart failure, or they have moderate to severe dementia in the presence of 2 or more activity of daily living impairment. So this is the treatment goals based on the category of the Bloom et al. Okay. So for healthy individuals, which has longer life expectancy, the reasonable A1C goal is less than 7 to 7.5%. The fasting glucose should be 80 to 130. The bedtime glucose should be 80 to 180. The blood pressure should be less than 140 over 90. And statin should be used for treatment of dyslipidemia unless it's contraindicated. For complex intermediate with intermediate life expectancy, the A1C goal is a little bit higher, which is less than 8%. The fasting should be 90 to 150. The bedtime glucose should be 100 to 180. And the blood pressure should be less than 140 over 90. And again, statin is indicated unless contraindicated. Now, for very complex or poor health with limited life expectancy, last year, the American Diabetes Association cutoff was less than 8.5%. But this year, in 2021, they put a reasonable A1C goal into advising us to avoid reliance on A1C as long as there should be no hypoglycemia and acute effects of hyperglycemia. The fasting glucose goal is 100 to 180. The bedtime glucose is 110 to 200. And the blood pressure goal is less than 150 over 90. Now, the role of statin for dyslipidemia is considered only if the likelihood of benefits will be considered for this patient. On your screen is the 2021 algorithm for treatment of diabetes type 2. First-line therapy is metformin. It's still true for older individuals. The second-line agents will depend on what your patients have. So the second-line agents will depend whether your patient has established atherosclerotic cardiovascular disease, CKD, or heart failure. And of course, generally in this population, we should avoid or minimize hypoglycemia. So what agent to be added as second agent to metformin? It depends on the tolerability of the side effects of this medication, which we will go through on our next on my next slides. So as much as we wanted for our elderly patients to avoid insulin, there are indispensable indications wherein we should use insulin for this type of patients, particularly for those who already have a progressive failure of the pancreas, wherein there's no more to produce insulin. And of course, we wanted to reverse the glucose toxicity as well as improve the well-being, quality of life, and cognitive function of our patients. So patients should be on insulin if they're already on diet, exercise, and oral medications, but despite of that, there's still failure to adequately control the blood glucose levels, or in instances wherein the oral medications are contraindicated, or incretin-based therapies are unsuccessful, or the random blood sugar is still consistently more than 180, and the fasting plasma glucose is still more than 140. And of course, those patients who just had acute MI, stroke, hyperglycemic coma, or major surgery should be put into insulin after the event. Okay, so let's go through the different agents quickly. So insulin can cause hypoglycemia. We all know that. In patients with CKD, the clearance is decreased and therefore pose an increased risk for hypoglycemia. And therefore, in this subset of patients, dosage adjustment should be done. In patients with CKD stage 4 to 5, they have already a delayed gastric emptying, and therefore we can give the short-acting or rapid-acting insulin postprandially to match the insulin peak together with the postprandial peak of their blood sugar. So in patients who have cardiovascular disease on prolonged insulin, they may have fluid retention when combined with the TZD. And of course, very important that hypoglycemia be avoided due to the risk of potential arrhythmias and stroke for this patient. So there are older individuals who's already on a very complex therapy. So they already on basal insulin plus a mealtime, short-time insulin. So how do we simplify it? So for the basal insulin part, we shift the basal insulin part to be given instead of the bedtime, it should be given in the morning. And then we adjust the dose, uh, thinking in mind the goal, which is 90 to 150. So if 50% of the glucose within the week is increased from the goal, we should increase the basal insulin by 2 units. But if there are values that are lower than less than 80, we should decrease the dose by 2 units. For mealtime insulin, it depends. If the mealtime insulin is more than 10 units per dose, we decrease the dose by 50% and we add non-insulin agents. We titrate the insulin until it is discontinued and replaced by the non-insulin doses. For patients who have mealtime insulin, which is less than 10 units per dose, we discontinue the mealtime insulin and just add a non-insulin agents. If your patient's eGFR is more than 45, we start with metformin, 500 OD, and decrease the dose every 2 weeks. If the eGFR is less than 45, we start with the second-line agents. So how about for those who are on premix? So we get the total dose of the insulin and 70% of which will be used as basal insulin to be given in the morning. So similar with the basal insulin I've showed, you just have to adjust it depending on the fasting plasma goal. Now, after adjustment, if 50% of the values in 2 weeks are above the goal, we increase the dose of the basal insulin or we add another agent. If the finger stick values within the week are less than 90 milligrams per deciliter, we decrease the dose of the medications. So very important to remember, we should never give short-acting insulin at bedtime because of the increased risk of hypoglycemia at midnight, or even very early morning. So if we need pre-meal insulin, so we can basically start them with simplified sliding scale. For example, if the pre-meal glucose is more than 250, we can just give 2 units. If the pre-meal glucose is more than 350, we can probably give 4 units of short-acting or rapid insulin. So for metformin, very popular. We already know the side effects of metformin. Commonly is GI side effects. Okay, it does not cause hypoglycemia if given alone. However, it may cause vitamin B12 deficiency and aggravate or worsen the neuropathy symptoms. That's why the recommendation of the Endocrine Society is for periodic testing of vitamin B12 levels. We should reduce the dose of metformin to 1,000 milligrams per day if the eGFR is less than 45, and we stop it if the eGFR is less than 30 milligrams per deciliter because of risk of lactic acidosis. For patients who are at increased risk for acute kidney injury, such as those who will undergo radioconscious die, or those who have hypotension, sepsis and septic shock or hypoxia, so we should stop metformin because of similar reason that it may cause life-threatening lactic acidosis. Your metformin was proven to be beneficial in patients with coronary artery disease. However, we should avoid this agent in patients with severe congestive heart failure. Sulfonylureas may cause hypoglycemia and weight gain. if we want to use sulfonylureas, we should avoid the long-acting agent, which is glibenclamide, which is very popular in causing hypoglycemia among elderly individuals. We can use the short-acting glimepiride as well as the glipizide, but remember, we should avoid these agents if the eGFR is already less than 30. Again, just like the insulin, we should avoid hypoglycemia, especially in patients with cardiovascular disease because of risk of arrhythmia and stroke. Glinides are basically just short-acting sulfonylureas. They have similar side effects. It can cause hypoglycemia, weight gain. We should stop it, particularly if the eGFR is less than 60, and we should prevent hypoglycemia. What good thing about the glinides is that this can be used by patients who's fond of skipping meals, because if it's it's a short-acting sulfonylureas. For TZDs, it does not cause hypoglycemia. However, it may increase the risk of fracture, particularly in postmenopausal women. And in a spectrum of cases, it may cause fluid retention and may worsen the heart failure. And of course, it may cause weight gain. In the proactive trial, your pioglitazone results in the reduction of 16% in the secondary cardiovascular endpoint. Alpha-glucosidase inhibitors, it may not cause hypoglycemia, but the GI side effect of flatulence may affect the adherence. This should not be given in patients who have a serum creatinine of 2 or more, because there was a lack of studies in giving this agent for such a population. DPP-4 inhibitors are one of the safest oral hypoglycemic agents to be given for elderly individuals. It does not cause hypoglycemia. However, in patients with CKD, majority of which needs dose adjustment, except for linagliptin, which has a very minimal renal clearance and therefore no need for dose adjustment. In the SAVOR-TIMI 53 trial, saxagliptin increased the risk of hospitalization for heart failure in 3 to 5% of patients. Okay, SGLT2 inhibitors, this does not cause hypoglycemia as well. Your empagliflozin, canagliflozin, dapagliflozin were proven in their respective clinical trials to reduce cardiovascular events as well as progression to chronic kidney disease. It may, however, cause volume depletion among older individuals. And in patients taking this agent, we should watch out for the presence of tachypnea, ketoacidotic breathing, and then when we get the blood sugar, it's normal. That's a typical profile of a patient developing euglycemic ketoacidosis from this agent. So for you to avoid this from happening, we should stop your SGLT2 inhibitors 24 hours from the time of the scheduled surgery or any stressful activities. In a majority of the completed clinical trials for SGLT2 inhibitors, it did not show any increased risk for fracture, except for canagliflozin, which was found to increase the risk of fracture, particularly in the arms and the legs. It also increase the risk of toe and foot amputations. Now, your SGLT2 inhibitors, as your GFR decreases, the effect likewise decrease. So we should avoid these agents if the eGFR is less than 45, basically because it's less effective once your GFR also decrease. Okay, it's the eGFR cutoff is a little bit higher for dapagliflozin, which is less than 60 milligrams per deciliter. It was reported likewise that canagliflozin and dapagliflozin were associated with acute kidney injury, probably because of some changes in the renal perfusion. However, one good thing about SGLT2 inhibitors is that these agents can reduce the major adverse cardiovascular events and congestive heart failure. Your GLP-1 receptor agonists are injectable non-insulin agents. They do not cause hypoglycemia if given alone. This side effect is problematic, particularly nausea. You should avoid this agent in patients with eGFR of less than 15. But your liraglutide and semaglutide were found to reduce major adverse cardiovascular events with a reduction of 13% for liraglutide and 26% for semaglutide. Just a summary of your agents with the classification of the risk of hypoglycemia. In elderly patients, we are for those agents which are low risk for hypoglycemia. These are your metformin, alpha glucosidase inhibitors, DPP4 inhibitors, incretin mimetics, TZDs, and SGLT2 inhibitors. Which one to start depends on the suitability on the patient. Okay, if these are uncontrolled, we may proceed with the moderate risk classifications and then with high risk, particularly with the use of insulin. Now, for patients who have hypertension and hyperlipidemia, so for individuals who are 65 to 85 years old, the target blood pressure should be 140/90. Okay, this was proven to decrease the risk of cardiovascular disease, stroke, as well as progression to chronic kidney disease. For high-risk groups, particularly those who have proteinuria, those with previous stroke, or those with progressing CKD, particularly with the eGFR of less than 60, the target blood pressure should be less than 130/80. For poor health, the target blood pressure should be 145 to 160/90. What agent to start? The first line, the recommended is ACE inhibitors. We all know that because ACE inhibitors decrease the risk of all-cause and cardiovascular mortality, decrease the risk of major cardiovascular adverse event, decrease the risk of heart failure as well as progression of retinopathy. If your patient cannot tolerate the ACE inhibitors, you may use the ARBs. But unlike ACE inhibitors, your ARBs is only capable of reducing the risk of heart failure. The most common agent to be added as after ACE inhibitor is your calcium channel blocker, particularly your amlodipine, because of its proven cardiovascular protection in the accomplished trial. Now, most of the clinical trials and meta-analysis did not mention or not look into the third or fourth agent to be added. So since volume is involved in patients with diabetes, then thiazide can be an appropriate third agent, except for individuals with an eGFR of less than 30, in which case your loop diuretic is more appropriate. Now, the fourth agent, particularly for those with coronary artery disease, is your beta blocker. Among all the beta blockers, your carvedilol has the least metabolic effects. Now, for management of hyperlipidemia, the Endocrine Society recommended to use in accordance with the lipid guidelines. Okay, but what we do know is that statin can cause a significant reduction in cardiovascular disease, both in primary and secondary prevention trials. And of course, it was proven that some patients or older patients who are on statin experience a 30% reduction in cardiovascular disease with minimal side effects. And in general, patients with diabetes should be on high-dose statin, irrespective of age, unless it's clinically or it's contraindicated. Now, if your LDL goal is elusive, despite statin therapy, then you may add ezetimibe or the pro-protein convertase subtilisin kexin 9 inhibitors. For patients who have fasting triglycerides of more than 500, the recommended regimen is fish oil plus fenofibrates to avoid the risk of acute pancreatitis. So on your screen is the LDL goal based on the risk categories. So basically, those who fall under extreme risk should have an LDL goal of less than 55. Those who fall under very high risk should have an LDL goal of less than 70. But generally, for patients with diabetes, the minimal LDL goal should be less than 100 milligrams per deciliter. So how do we address the congestive heart failure in patients with older patients with diabetes? So it has been said that older patients with diabetes has 30% risk of congestive heart failure. In the REACH registry, wherein it's composed of older individuals with diabetes above 68 years old, the risk of hospitalization for heart failure is high, which is 33%. So in the systematic review of the observational study, which comprised of 34,000 patients with diabetes and congestive heart failure, the result linked that the glinides can be associated with heart failure. TZDs, particularly rosiglitazone, was associated with increase in all-cause mortality and hospitalization for heart failure. The TCD, it's less with the pioglitazone, which have shown a decrease in all-cause mortality in 94 randomized clinical trials. Of course, I've mentioned a while ago that among the DPP-4 inhibitors, saxagliptin increased the risk for hospitalization for heart failure. Liraglutide was proven to have a significant cardiovascular benefits. The following SGLT2 inhibitors in their respective trials results to reduction of the hospitalization for heart failure, 35% for empagliflozin, 20% for canagliflozin, and 17% for dapagliflozin. Now, patients who are older carries a higher risk burden of atherosclerosis, and I think starting them with aspirin will have some benefits after assessment of the bleeding risk. So the Endocrine Society recommended that for patients who are 65 years and older with history of atherosclerotic cardiovascular disease, low dose aspirin is recommended for secondary prevention of cardiovascular disease after careful assessment of the bleeding risk. So the following agents likewise have shown a significant cardiovascular benefits in patients with atherosclerosis. So it was proven that control of hyperglycemia may likewise decrease the progression of retinopathy in both type 1 and type 2 patients with diabetes. The use of ACE inhibitors and ARBs was likewise found to have significantly decreased the risk of retinopathy. In the failed trial using fenofibrate, it has been shown that patients who are on fenofibrate resulted to a decrease in laser treatment for patients with diabetic eye disease. So, which suggested that fenofibrate may decrease the occurrence and progression of retinopathy. Now, of course, it's recommended that there should be an annual comprehensive eye examination among this population. Very important to note is to minimize the fall risk among these patients. There should be minimization of the sedative drugs or drugs that may cause orthostatic hypotension and hypoglycemia. TZDs and SGLT2 inhibitors may worsen the fall outcome by increasing risk of fracture. Very important is to emphasize physical therapy. And regardless of any nature, a decline in EGFR can affect drug dosing and some care of patients with diabetes. And therefore, this should be monitored annually by requesting for urine albumin to creatinine ratio and EGFR. But for those who have an EGFR of less than 60 ml per minute to begin with, the monitoring should be more frequent so that the subsequent dose or any care for this patient should be adjusted based on the EGFR of the patient. So let us not forget that older adults with diabetes should be given annual vaccination against influenza. They should receive pneumococcal polysaccharide vaccine and 3 doses of hepatitis B vaccine. So in summary, I would like to emphasize that in older individuals with diabetes, we should be careful in assessing the overall health conditions because this framework will be our basis for treatment strategies and goals. And of course, if we use this one, we simply have done individualization of sensible treatments based, of course, on their overall health framework. And keeping always in mind that we should avoid hypoglycemia, and of course, not to forget to avoid likewise hyperglycemia. And of course, education is very important both for patients and for caregivers. So I think that's my last slide, and thank you everyone for listening.
For the next lecture, let us learn about the concepts and approaches of different endocrine dyslipidemia. This session is presented by Dr. Florence Santos, the Chief of Section of Endocrinology at Mary Mediatrix Medical Center, and is a member of the Training Core and Technical Review Board of the Department of Internal Medicine of Batangas Medical Center. This session will also be moderated by Dr. Abigail Lejos Cure.
Good morning. I would like to thank the organizers of this first Tiger Eye and Postgraduate course for inviting me to talk on this topic of endocrine dyslipidemia. Dyslipidemia is a common occurrence or common consult of patients in the endocrine clinic. And in this lecture, we will cover the role of lipids in the diagnosis of endocrinopathies, the contribution of lipid function to endocrine health, the occurrence of dyslipidemia in endocrine diseases, and the impact of lipids on the clinical course. These are my disclosures. I am participating in some diabetes and dyslipidemia clinical trials, but none of the raw data nor the preliminary data will be included in this presentation. Okay, so for the outline of our discussion, we're going to have a very brief introduction to lipoprotein metabolism, a discussion of endocrinopathies with dyslipidemia, and eventually we're going to approach the treatment. We're going to discuss the treatment of dyslipidemic endocrine patients based on most recent guidelines. Okay, so this picture might be very familiar to all of you because this is from the horizons. So this is showing us the exogenous and the endogenous metabolism of lipids. Okay, so these are the two metabolic pathways of lipids. On the left side panel, okay, we have the exogenous pathway. The dietary cholesterol, the fatty acids, and the fat-soluble vitamins are absorbed in the proximal small intestine. This would eventually be undergoing esterification to form the chylomicrons, the blue circles, which are accompanied by our apolipoprotein C, B, and E, which are acting as ligands. Okay, these particles would encounter eventually in the circulation. They would be involved in the circulation with the lipoprotein lipase, and eventually would be undergoing hydrolysis, and free fatty acids will be released, taken up by the muscles and the adipose tissue, and eventually this chylomicron will be undergoing shrinkage, forming the chylomicron remnants, and rapidly removed from the circulation by the liver. So that is the exogenous pathway. On the right side panel, okay, we have the endogenous pathway. So as with chylomicrons coming from the liver, now they're containing the apolipoprotein B, which has a higher ratio of your cholesterol and triglyceride. The triglycerides of VLDL are hydrolyzed by the lipoprotein lipase, also in the muscles, the heart, and the adipose tissue. And after that, the VLDE remnant will actually dissociate from the lipoprotein lipase, and they are referred to as the intermediate dense lipoproteins, which contain roughly similar amounts of cholesterol and triglyceride. The liver would remove approximately 40 to 60% of the intermediate dense lipoproteins, and the remainder of the IDL is remodeled by the hepatic lipase to form the LDL. So this slide would show us the density and size distribution of the major classes of lipoprotein particles. They are classified by density and size, which are inversely related, with the largest particles being the most buoyant and the smallest particles being the most dense. The chylomicrons are the most lipid-rich, so again, the blue circles. They're the most lipid-rich, and therefore they are the least dense lipoprotein particles, whereas the HDLs have the least lipid and therefore the most dense lipoprotein. Okay, looking closely at the lipoprotein, it consists of the triglycerides and the cholesterol esters at its core, and the phospholipids and the free cholesterol at the outer layer of the apolipoproteins, which are acting as ligands for the cell surface receptors. Okay, so this is the HDL metabolism. It's quite intricate, but then we have to review these pathways. Okay, so the cholesterol in the peripheral cells is transported from the plasma membranes of the peripheral cells to the liver and the intestine. This is the process where this is termed as the reverse cholesterol transport that is facilitated by the HDL. You can see here that the nascent, HDL particles are synthesized in the intestine and the liver. They somehow produce a newly secreted apolipoprotein A1, forming a very discoidal HDL particle. Okay, so this discoidal particle would undergo esterification by the LCAT. So the LCAT is the lecithin cholesterol acyltransferase, which is a plasma enzyme associated with HDL and more cholesterol esters, which is being recruited until the HDL becomes more spherical. As you can see, the green HDL, which is the mature HDL and more spherical. Okay, so the HDL cholesterol is transported, to hepatocytes by both an indirect and direct pathway. So these are through the action of the cholesterol ester transfer protein, or the CETP, which are removed from the circulation by the LDL receptors through endocytosis, and the scavenger receptor B1, which is a cell surface receptor that mediates the selective transfer of lipids to cells. Okay, so dyslipidemia is a collective disorders of lipoprotein metabolism. It is generally characterized by clinically by increased plasma levels of cholesterol, triglycerides, or both, variably accompanied by a reduced level of HDL cholesterol. It is a genetic predisposition, which is often polygenic, and it can also come about because of environmental contribution, such as lifestyle, medical condition, and concomitant drug intake. Okay, so lipocrinology actually was coined by an Indian professor, and this is the study of the interrelationship between lipid metabolism and the endocrine function in health and disease. Once dyslipidemia has been diagnosed, secondary causes of the disorder must be excluded, to rule out cases that could be treated or cured with approaches that do not involve cholesterol or triglyceride lowering mechanisms or medications. The diagnosis of the secondary causes should begin with the complete medical, family, and nutrition history. Okay, a physical examination must be undertaken, to identify additional risk factors, including genetic features. Okay, so you can see here the different endocrine conditions, that could be occurring towards lipid dysfunction together with an endocrine dysfunction. So this encompasses a spectrum of diseases correlating dyslipidemia and endocrine diseases such as your metabolic conditions such as your diabetes mellitus, your metabolic syndrome, even your obesity. Okay, thyroid dysfunction such as your hyper and hypothyroidism, your growth hormone excess and deficiency, and even your reproductive dysfunction such as PCOS, hypogonadism, menopause, and even adrenal conditions such as Cushing's syndrome. Okay, due to the limited time, we will only focus our discussion in the most common endocrinologic diseases with emphasis on patient's profile and how to approach treatment. Okay, so this is case 1, MF, a 59-year-old male, an accountant, who sought consult for the results of his annual PE. So he's known diabetic for 5 years, known hypertensive for 3 years, occasional smoker, and non-alcoholic beverage drinker. There's apparently no pertinent symptoms at the time of consult except for a bearable chest discomfort, which was last experienced a year ago. So he claims to have a very sedentary lifestyle, being an accountant, and the family history is positive for CBD infarct with an older sibling, who also has type 2 DM. Okay, so the BP was found to be at 145/90, and patient is obese at 30 BMI. And his current medications are fixed dose combination of your irbesartan amlodipine 150/5, your fixed dose combination of sitagliptin 50/5, and metformin 500 milligrams, which was taken twice a day, vitamin E at 400 IUD, and atorvastatin 20 milligrams every day. you can see from the labs that he has fairly controlled blood sugar with FBS of 140 milligrams and HbA1c of 7.9%. And glaringly, you can see that there's a occurrence of dyslipidemia with the cholesterol high at 230 milligrams. The triglyceride is also high at 260 milligrams. And all the other parameters are actually abnormal. Okay, the creatinine and the SGPT are actually both normal. Okay, so looking at this patient, okay, so you can see that for the salient features is hypertensive, obese, has smoking history, family history of CVA, and has a very sedentary lifestyle. Plus the parameters showing with a poorly controlled blood sugar and dyslipidemia. Okay, so dyslipidemia actually is one of the most significant cardiovascular risk factor. With the increasing prevalence of type 2 DM globally, and the current and there's a current 463 million patients having diabetes, this epidemic will be followed by a wave of cardiovascular disease. Diabetes is considered to be a cardiovascular disease, and it will not only be hyperglycemia that we should focus on, but rather other cardiovascular risk factors to lessen morbidity and mortality. Okay, and dyslipidemia is the most common cardiovascular risk factor. Many patients with type 2 DM are characterized by a typical dyslipidemia, which we pertain as the diabetic dyslipidemia triad. This is composed of a low HDL cholesterol, high serum VLDL triglycerides, and a preponderance of small dense LDL. Okay, so the lipid particles are considered to be more atherogenic. This was shown in several biochemical studies. Numerous studies have demonstrated that DM or diabetes is associated with premature atherosclerosis and that it is more linked to diabetic dyslipidemia than to hyperglycemia. Okay, so you can see from this slide, okay, in terms of the small dense LDL, this is considered to be a major factor for atherosclerosis, mainly because it is easily oxidized and binds more readily to the proteoglycans of the arterial wall. It's also considered, as shown in several studies, that this is an independent determinant of the intima media thickness. It's also considered to be an independent predictor of the coronary artery disease in healthy men. And it's also considered to to show very early signs of vascular injury or endothelial dysfunction. On the left side panel, you can see that this is a slide taken from the Strong Heart study, and it shows here that there's a stepwise decrease in the LDL size according to the diabetic status, from normal to impaired glucose tolerance and eventually to diabetes. Okay, this association is most striking in women, and maybe this is one reason, okay, why women lose the sex-specific cardioprotection when they are diabetic. Okay, so looking at this slide, so this is a diagram that shows the enzymes, the transfer proteins, and the apolipoproteins regulating the metabolism of HDL. So in diabetes, the concentration of HDL cholesterol is actually reduced. And this is also in terms of the composition and the distribution of the HDL. The changes in HDL in type 2 diabetes are mediated via two pathways. One would be the plasma triglyceride elevation, and second would be the reduced ratio between lipoprotein lipase and hepatic lipase. This would lead to the modulation of HDL composition, which would lead to an enhanced catabolic rate of the HDL in the circulation, leading to lower HDL levels. And all of this mechanism would actually be secondary to insulin resistance. Okay, so in terms of hypertriglyceridemia, okay, this slide would further elucidate the role of insulin resistance in the generation of hypertriglyceridemia, which is a common lipid abnormality in diabetes. The overproduction of the triglyceride-rich VLDL1 is considered to be central, to be a central lipoprotein abnormality of diabetic dyslipidemia, and can promote generation of small dense LDL particles and reduce the HDL cholesterol levels. Okay, so major sources of the fasting triglycerides would be fatty acids, okay, from the adipose tissue that enters the liver. fatty acids derived from chylomicrons and the VLDA remnants and taken up by the liver, and the fatty acids derived by de novo lipogenesis. Okay, so the following slides will be dealing on how we are going to treat patients with diabetes and with dyslipidemia. So most of the slides will be coming from the latest Endocrine Society guidelines for clinical practice guidelines, which was published in October 2020. And you will see here that the Endocrine Society actually used the grade classification of guideline recommendation, meaning that the quality of evidence was categorized whether they're high quality, moderate quality, low quality, and very low quality. And they will be represented by small circles, which are being filled up at the side of the guideline. In terms of the strength of recommendation, they're considered to be either strong, which would be numbered 1, and conditional, which would be numbered 2. Okay, so in terms of dyslipidemia in diabetes, statin therapy and lifestyle modification in order to reduce cardiovascular risk is highly recommended. So this is a strong recommendation, and in terms of the it's being highly recommended, and in terms of its grading in the guidelines, it's actually has a very highly recommended. Okay, so high-intensity statin should be chosen in patients with ASCVD or those with risk factors for atherosclerotic cardiovascular risk or risk-enhancing factors. Okay, so it cannot be used to pregnant women or for those patients who are trying to get pregnant. And for those who are older patients, like for example, more than 75 years old, the continuation of statin, if with ASCVD risk, if the prognosis is still good, okay, if there's a potential interacting medication, you have to consider this. And if the patient is receiving polypharmacy, in terms of the mental health of the patient and the wishes of the patient. So all of this needs to be considered if you're going to continue your statin therapy. Okay, so just to show you the different, in terms of intensity, statin therapy. So on the left side will be your high intensity statin therapy, which are believed to lower LDL cholesterol by equal or more than 50%. And among this would be your atorvastatin 40 to 80 milligrams and your rosuvastatin 20 to 40 milligrams. On the right side will be your moderate intensity statin therapy, which are believed to lower LDL cholesterol by 30 to 49%. And among this would be your lower dose of atorvastatin 10 to 20 milligrams, rosuvastatin 5 to 10 milligrams, simvastatin 20 to 40 milligrams, pravastatin 40 to 80 milligrams. We have a new agent in the market, the pitavastatin, wherein it can be considered to be moderate intensity statin therapy at 1 to 4 milligrams per day. Okay, so lowering the LDL to achieve a goal of less than 70 milligrams in order to reduce cardiovascular risk. So you can see here that in terms of strength of recommendation is only 2. Okay, in terms of the grade or the grade of classification would be only very low. Okay, so they say that the statin added to lifestyle modifications of LDL cholesterol of more than 70 milligrams per DL, but then there are some studies now showing, or some guidelines showing that the LDL-C should be less than 55 milligrams per DL, specifically for patients who have established ASCVD or having multiple risk factors. So additional LDL lowering therapy can be in the form of ezetimibe, okay, your newer molecule, the PCSK9 inhibitor, and they may be needed if your LDL cholesterol goal is not reached with statins. Okay, so type 2 DM on a statin and already had reached the goal, but with residual triglycerides over 150 milligrams per DL, and with 2 additional risk factors or risk-enhancing factors, you may add your eicosapentaenoic acid or your EPA ethyl ester to reduce cardiovascular risk. Although the recommendation is only conditional, okay, but then you can see that in terms of the in terms of the grade would be around moderate, okay, moderate grade in terms of the recommendation. So they consider giving 4 grams per day of your EPA ethyl ester. And if it's not available or not accessible, then it would be reasonable to consider a fibrate wherein they recommend fenofibrate for the choice of agent. Okay, so this is a special population for patients who are having type 2DM with chronic kidney disease, just to show you that in terms of the stages of CKD 1 to 4, for those who underwent post-renal transplant, they suggest statin therapy irrespective of the cardiovascular risk score. This is to enable these patients to reduce cardiovascular risk. Although, again, this is just conditional in terms of the recommendation, but then you can see here that in terms of considering statin therapy for these patients, you have to consider, okay, the renal clearance of these patients. And in terms of the clearance, okay, for those agents who are cleared through the kidney, there are pitavastatin, pravastatin, and rosuvastatin. And your atorvastatin, fluvastatin, luvastatin, and simvastatin are actually cleared via the liver. So you just have to bear in mind, okay, the route, okay, that they're being cleared, so that you will be able to choose, okay, which is the right agent, okay, for your CKD patients. Okay, so all statins require dose adjustments in chronic kidney disease, except for atorvastatin and fluvastatin. Okay, so you can see here the different classifications of metabolic syndrome, how it had evolved, okay, through the years. But then, so far, we have been using the International Diabetes Federation criteria for metabolic syndrome, which was coined in 2005. And you can see here that putting central obesity as the main criteria, okay, for a metabolic syndrome, it's being accompanied by the level of the triglycerides of equal or more than 150 milligrams, or the level of the HDL cholesterol, which is less than 40 for males and less than 50 for females. You can see that lipids are still one of the major components of metabolic syndrome. Okay, so how about hypertriglyceridemia? Okay, so in adults with fasting triglyceride levels over 500 milligrams per DL, we recommend pharmacologic treatment as adjunct to diet and exercise to prevent pancreatitis. Okay, so this is strongly recommended, although in terms of grading, it is a very low grade in terms of its classification. Okay, so the patients with triglyceride levels over 1,000 milligrams per DL often do not get an adequate response to medications. And therefore, the control of diabetes, modification of diet, and weight loss are really very essential to these patients. Okay, so in patients without diabetes and who have triglyceride-induced pancreatitis, we suggest against the routine use of insulin infusion. Now, why? You can remember that in the pathophysiology of hypertriglyceridemia, insulin resistance actually play a role. Okay, but then it will not be recommended, okay, that you use insulin infusion to induce hyperinsulinemia to treat these patients. However, if your patient has uncontrolled diabetes during the time that he is hypertriglyceridemic, insulin therapy can be used to normalize glucose levels and likewise to improve the triglyceride levels. Okay, so adults on statins and still have moderately elevated triglyceride levels of more than 150 milligrams and who are having either ASCVD or diabetes plus any two traditional or additional risk factors, suggest adding the EPA ethyl ester to reduce the risk of cardiovascular disease. So the dose again of your EPA ethyl ester would be 4 grams per day. And if the EPA again is not available or accessible, then it is reasonable to use or to consider a fibrate therapy. Okay, so going back to our patient who is having a fairly controlled blood sugar and dyslipidemia. So what we did to this patient, we maintained the fixed dose combination of irbesartan amlodipine, the fixed dose combination of sitagliptin and metformin, and we added, okay, dapagliflozin, 10 milligrams once a day. We increased the atorvastatin, 80 milligrams once a day, and we added, okay, the EPA plus DHA, 1,000 milligrams 4 times a day. And then the patient was advised to follow up for 3 months. Okay, so for our second case, we have MC, a 40-year-old female, non-diabetic, non-hypertensive, who complained of body weakness and occasional dizziness. She had been having menorrhagia and consulted with OB-GYN with an unrecalled medication. And she also noted weight gain. Patient underwent near total thyroidectomy a few years ago, and histopath showed adenomatous goiter. Patient's BP was 130/80 at the clinic, and the cardiac rate was at the low side of 62 per minute. She was seen to have facial edema, but the patient claims to notice this only upon waking up. And there was also grade 1 pitting bipedal edema, and the patient also claims that it's only present with prolonged standing. Okay, for the ancillary and laboratory results, so chest X-ray showed mild cardiomegaly, ECG showed a non-specific SCT wave changes, FBS is good at 101, creatinine is normal, the electrolytes are normal, and you can see here that the lipid profile again is abnormal. So high cholesterol, high triglycerides, high LDL, and the low HDL. And the TSH actually was found to be elevated at 25 mil. Okay, so the FP4 is also low at 4 picograms per mil. Okay, so in terms of thyroid disorder, so this is actually the list of the different conditions that would bring about hypothyroidism. So we have endogenous causes, which is most likely secondary to thyroiditis. In terms of exogenous causes, you can have inadequate L-thyroxine treatment for overt hypothyroidism. We can have overt treatment with antithyroid medications. It can be secondary to radioactive iodine ablation, subtotal or total thyroidectomy, and the other causes for exogenous causes. Okay, so you can see here that in terms of the elevations in total cholesterol and low density lipoprotein cholesterol that is occurring in hypothyroidism, this is due to several changes in the synthesis, in the metabolism and mobilization of lipids. Okay, so the effects of thyroid hormone are as follows. It induces the hepatic expression of your HMG-CoA reductase, increasing the cholesterol synthesis. So if you have low thyroid hormone, meaning you're going to have decreased cholesterol synthesis. It also increases the expression of cell surface LDL receptors, which is mediated via your sterol regulatory binding protein, which is directly related by T3. So meaning that, again, if you have low thyroid hormones, you're going to have decreased expression of the LDL cholesterol receptors. And this would lead to decreased clearance of LDL cholesterol from the serum. Okay, so other conditions would be your cholesterol ester transfer protein, or your CETP. It transfers the cholesterol from high density lipoprotein, or the HDL cholesterol, to LDL cholesterol and the VLDL. The plasma CETP concentrations are decreased in hypothyroidism and increase in hyperthyroidism, which may lead to alterations in both the serum LDL or the serum HDL cholesterol and your triglycerides. Okay, so the lipoprotein lipase lowers the triglyceride levels through hydrolysis. And then this triglyceride-enriched lipoproteins and facilitation of the cholesterol transfer from these lipoproteins to HDL cholesterol. Okay, so the lipoprotein lipase activity is increased, by thyroid hormone. Therefore, hypertriglyceridemia may develop in hypothyroidism. Okay, so this slide will show you, the different lipid abnormalities in the different thyroid dysfunction. In hyperthyroidism, overt hypothyroidism, and subclinical hypothyroidism. Your hyperthyroidism actually would have a lot of effects in the cardiovascular system. But surprisingly, in terms of dyslipidemia, the parameters actually are all decreased, meaning that they would have decreased cholesterol, LDL cholesterol, and even the HDL would also be decreased. Okay, in the overt hypothyroidism, as discussed previously, it can have an increase in the total cholesterol as much as 30%, the LDL cholesterol can increase as much as 30%, and even your HDL cholesterol can be normal to slightly increase, which is actually beneficial to our patients. And then your triglycerides can also be normal to increase. Okay, so your subclinical hypothyroidism can also present with some lipid abnormalities. Okay, so in terms of treatment guidelines for hypothyroidism with dyslipidemia, so we recommend, okay, the society recommends, okay, that we have to rule out first hypothyroidism as the cause of the hyperlipidemia before treatment with lipid-lowering medications. Hypothyroidism can elevate both the cholesterol and the triglyceride levels, which can be improved, okay, with treatment of the hypothyroidism. And in patients with hyperthyroidism, they recommend re-evaluating the lipid panel after the patient becomes euthyroid. So there could be changes in the LDL cholesterol, and this had been observed as early as 3 months after the patient had been rendered euthyroid. Okay, so also in patients with overt hypothyroidism, they suggest against treating hyperlipidemia until the patient becomes euthyroid in order to more accurately assess the lipid profile. Okay, so in patients now with subclinical hypothyroidism, that is TSH of less than 10, okay, with associated hyperlipidemia, they suggest considering thyroxine treatment as a means of reducing the LDL. But somehow, some of the technical remarks noted that we have to take into consideration the patient's age and the general health, the possibility of suppression of the TSH, and whether the patient has cardiovascular disease. So we have to keep in mind, okay, the side effects or the possible adverse effect of your levothyroxine or your thyroid hormone. Okay, so this list shows us the different metabolic conditions, endocrine metabolic conditions, okay, that would be presenting with dyslipidemia. So again, your metabolic abnormalities of diabetes, obesity, and then your thyroid dysfunction, okay, and then your adrenal dysfunction such as having Cushing syndrome, even your chronic glucocorticoid therapy, your excess and deficiency of growth hormone, and even your reproductive dysfunctions, and even those patients on HRT, patients who are having hypogonadism, those who are receiving testosterone therapy or having anabolic steroid abuse, and those who are having gender-affirming hormone therapy, such as those who are trans men or trans women. All of these patients actually can present, okay, with dyslipidemia. Okay, so just to point out some of the more common endocrinopathies, like for example, for the PCOS, it can present with increased LDL cholesterol, triglycerides, and lipoprotein A, and decrease in HDL. For acromegaly, you can have decreased triglycerides, low HDL, and high lipoprotein A. For the Cushing syndrome, they can present with hypercholesterolemia. For hyperthyroidism, again, they can have low total cholesterol, low LDL, low HDL, and low lipoprotein A. For hypogonadism, specifically in male, they can have high LDL cholesterol, high triglycerides, and decreased HDL-C. And for menopausic women, they can have increase in LDL-C with either no change or a small decrease in HDL-C. Okay, so for our lipocrinology pearls, broad interrelationship between lipids and endocrine system had been demonstrated. Dyslipidemia is a major contributor to endocrine and metabolic health, and that dyslipidemia is an important cardiovascular risk factor in different endocrinopathies, and endocrine dysfunction merits lipid profile investigation and subsequent treatment. So I think that's my last slide. So thank you very much, okay, for listening.
Diabetes affects around 422 million people worldwide, with increasing prevalence every year. It causes several complications, such as increased risks of cardiovascular disorders, neuropathy, blindness, and kidney damage. However, People with diabetes still live long and healthy lives with early diagnosis and intervention. Don't let uncontrolled diabetes take control. Start early and stay healthy with Glycelin G, the world's first glargine biosimilar. Glycelin G has a consistent activity profile and better safety profile compared with NPH insulin in basal-supported oral therapy regimen. It is associated with a lower incidence of nocturnal hypoglycemia and lower incidence of new micro and macrovascular complications. It is also proven to be more effective in decreasing hemoglobin A1C, fasting blood glucose levels, and glucose variability. Additionally, Glycelin G has a protective effect against cardiovascular mortality, as it positively affects lipid parameters and modestly reduces CIMT progression. It also provides 24-hour action with once daily dosing. Glycelin G is also proven to be bioequivalent with the Innovator brand, comparable in terms of effectivity and safety. Glycelin G is proven to be safer and more effective compared with NPH insulin, is convenient with once daily dosing, and is bioequivalent to the Innovator brand. Don't let diabetes take over. Glycelin G, the world's first glargine biosimilar.
You may now proceed to our industry-sponsored symposia. Please go to www.tiktok2021.com and click on the room you would like to join.